request Dr. Shahi to take over and introduce our speaker, Dr. Ronit.
Okay, thank you. So before doing that, I just good evening to just say good evening to everyone, and just wanted to start today by thanking you all, and especially Pratibha Singhi. She's always there, and Professor Rekha Mittal, always involving us in Bangladesh in these wonderful sessions. And our student, and actually all of us in Bangladesh, we are lucky to be able to learn from you, and we are grateful to have this benefit from this exchange program across the borders, especially during this pandemic. So now I start. Today's section is Spasticity Management in Children, and by Dr. Ronit Mesterman. And she is an associate professor of pediatrics at McMaster University. She is certified in pediatric neurology and developmental pediatrics. She is the division head of developmental pediatrics at McMaster University and medical director of developmental pediatric rehabilitation and autism spectrum disorder service at the Ron Joyce Children's Health Center, McMaster Children's Hospital. And her dual training reflects her philosophy that developmental pediatrics and child neurology go together, and as such, she is working clinically in both the divisions. Her main clinical and research interests are assessment and treatment of cerebral palsy. She has established a very busy multidisciplinary spasticity clinic, and she is a collaborator in CPNet, a database on cerebral palsy in Ontario. So please, Dr. Ronit, just carry on.
Thank you.
Dr. Ronit, you can share your screen.
Yeah. Okay, is it visible? Yeah. Okay, so thank you very much for the invite to present in this established forum. Okay, sorry, I'm trying. Okay. So my plan is today to provide an overview on tone. Specifically, I was asked to talk about spasticity, but I'll take it a little bit broader. So we'll talk about tone in general. And then I will walk you through various medical interventions. I will tell you in advance that I will not cover everything because that would have gone beyond the 45 minutes that I was allocated. And I will focus on the medical interventions that we as neurologists are often involved. And at the end, I will try to really apply to some specific clinical scenarios and cerebral palsy. And I hope that we'll have time indeed to discuss. I'm sure that most of you are fully aware of the definition of CP, but that's how I like to start every talk to make sure that we're all on the same base. Cerebral palsy has had many versions of definitions. The last one in 2006 was actually led by my esteemed mentor and colleague, Peter Rosenbaum. The first sentence is really highlighting the core definition of CP, that CP is a group of permanent disorders of the development of movement and posture, causing activity limitations that are attributed to non-progressive disturbances. And I will focus today on the core features with hypertonia. But I do like to always mention in my talks that really CP is so much more. And the second sentence was really the driver for the revision of the definition to put more emphasis on the non-motor components that is accompanying the patients with CP. But I will not go into that too much, besides the secondary musculoskeletal problems that are intertwined with the hypertonia. Cerebral palsy is really a bag of conditions. It's an umbrella term to describe many different conditions that present in many different ways. In developmental peds, we do have, for most conditions now the definition of a spectrum disorder. We don't use this term in CP, but truly it is a spectrum disorder in the sense that we have many different types. So we have subcategories that we subcategorize by the type: spastic, dyskinetic, and ataxia, with the spastic subtype being the predominant one. We have a topographic distribution differentiating between hemiplegic, diplegic, and quadriplegic. And the reason I put in brackets unilateral and bilateral is that we have a bit of a difference in the expression, whether it's the European group that is more going by unilateral and bilateral versus the North American that are still holding on to the more traditional distribution. And then last not least, we have in the last 20 years recognition of the different functional level. Initially the gross motor functional classification level 1 to 5, followed by the manual ability classification, and lately the CFCS, and we now also have a classification for children with CP on swallowing and feeding. Okay, so when I was invited to this talk, I was asked to speak specifically about spasticity. But I will have to take a step back and actually highlight that not every muscle in a patient with CP that feels stiff is actually equaling spasticity. The majority will have spasticity indeed, and that is characterized by a velocity-dependent resistance to a stretch. So we know that when we make the slow movement, we feel tone, but when we do a quick movement, it is presenting with a typical spastic catch, after which, as long as the muscle is not fully contracted, we can still further extend the movement. The character of the dystonic muscle is more of an involuntary muscle activity that results in abnormal posturing of extremities. When we apply this exam in arms and legs, typically the tone is not affected by the speed of the movement. Those two different types of tone are resulting from different disruptions in the pathway. And as often in medicine, the differentiation is clear on exam, but in the reality, the patients are often having a mixture of those. Even if the predominant type might be spasticity, it is important to understand that many patients have superimposed also dystonia. To help us be more sensitive to the separation, my colleagues in Toronto have developed the hypertonia assessment tool that really gives a good manual on how exactly to get down to the essence of those two different types. I did not address that there is a third type of tone that we call rigidity, which we often see in adults, especially in the context of Parkinson, but is actually very rare in children. So when we talk about hypertonia, it is important to recognize that this is part of the positive features of an upper motor neuron lesion that goes with hypertonia. And again, I'm now putting together the hypertonia as in spasticity and dystonia. And I want to make clear that I am aware that dystonia is not regarded as an upper motor in the sense that we typically talk about spasticity. The patients will often, as other plus positive features, have increased reflexes and sustained clonus. And many patients come to us really with the worry that this stiffness must be in the way of their function, and therefore coming with the hope that we can reduce the hypertonia to really make them better. And this is really what my talk is today about, to see, can we do this better and how much will this change the function? But it's really important to recognize that in the patient with CP, or generally speaking with upper motor neuron lesions, there are a list of negative features that are very important in the consideration, and they together with the positive features will affect the function and the abilities. On this list is the muscle strength. Often enough there is an underlying weakness, the endurance, the ability to control the muscles, the selective control, and the sensation. Often these features are on the decreased side and will impact the abilities. And they really have to be integrated in our treatment with hypertonia. It's not a standalone to address the hypertonia without taking all of these elements into consideration. But today, or at least for the first half of my talk, I will really focus on the hypertonia. There are many different treatment options for hypertonia that I will try to address today. We can separate the treatments into different groups. There are the treatments that are reversible versus irreversible. And there are the treatments that are more targeting the focal muscle versus just generalized hypertonia treatment. As I mentioned before, I will predominantly address the interventions that are even delivered by us as neurologists, but also where we as neurologists often have to channel. I will not as much go into the orthopedic procedures, and I will also not go into physical management because it's a huge chapter that is very important, of course, but it just is beyond the scope of my talk today. Okay, let's start with the oral medications. And again, I'm trying at times to separate, especially when there are differences. So we have the medication that we typically use for spasticity, which include baclofen, diazepam, tizanidine, and in the literature it is mentioned the dantrolene, but I have to be very upfront that I've never used it, and I have not met between my colleagues anyone that is actually using it, so I won't be too much about it. And then the medications that are endorsed to some extent to be used for dystonia, baclofen, Arten, and L-dopa. So when I have prepared this talk also before for my learners, I have reviewed the literature, and until not long ago, there was very little, surprisingly, of randomized controlled trials really assessing these medications that seem to be commonly used. There have been some early papers in the 60s and 70s that looked at the use of baclofen with small numbers, nice study designs, but small numbers were double-blinded, placebo-controlled. Especially when we look at the older papers, they often do not separate by GMFCS levels, functional levels, because it didn't exist at that time. And we also don't see as much as we do these days, more indications of actually the functional gains. So the majority of those papers are focusing on the change in tone, using often the Ashworth scale, some the Tardieu scale, and they definitely, throughout the papers, are able to identify that the medication is indeed reducing tone. And that is true for baclofen, it's true for the benzodiazepines and tizanidine. By the way, tizanidine, I could not find any paper actually in English, so I could only read the abstract. And as I mentioned, unfortunately, none of the papers, even the latest coming out of India, which was a very nice study design, has actually not commented on the functional goals in these children. And this theme will occur again when we assess the literature for its evidence. It is clear that we have sometimes a paucity of research evidence to support a treatment, but I think we need to be very careful to not throw out the baby with the water, because we still are all clinicians and we should still take every case by case. Part of the challenge with these studies are that we often lump a lot of children under the label of CP into one study protocol, while they're actually very different in their baseline functional level, and so would probably be the goals for change in function. So when would I still consider oral medication with all the limitations of the evidence is when we're dealing with diffuse generalized hypotonia, especially when a patient has symptoms consistent with more muscle spasms, which are painful. So definitely the component of painful muscle contractions would be responding to baclofen. I personally use baclofen also sometimes when I see a combination of high tone and the parents are having difficulties with sleep of the child. I will admit this is in a way an off-label use. I'm using the side effect of baclofen that causes sedation. So by no means do I want to make it sound as if that is evidence, but I find in the younger children, a small dose given only in the evening has actually good effects at times. Another principle that I would like to also share is that in tone management, when using oral medications, with higher doses, we will typically see more side effects. And that is true for many medications in other fields as well. As neurologists, we're often trained, especially in the epilepsy management, that we will max out first one medication before we drop and go to the next one. In one way, that's the same for spasticity management, but I still would say I would not push it as far in regard of the side effects, while actually trying to combine even medications in lower dose. They sometimes are quite synergistic to each other. What to watch when we use oral medication? Because it's a systematic approach, the medication doesn't differentiate between the muscles that are truly stiff and the muscles that are actually low tone. We know that hypertonia, especially affecting arms and legs, is often coexisting with low tone of neck and trunk. And unfortunately, we often see that the decreased tone gets worse in the neck trunk, in especially younger children, before we even reach a true efficiency on the peripheral limbs. So that is a thing that one needs to watch and balance out. Increased drooling is a common side effect of many of the oral especially the baclofen, and in some children can really worsen their swallowing problems and their breathing issues. I had a few kids who really decided to have, not decided, but reacted with actually quite significant obstructive sleep apnea, and were much better when we took them off the baclofen. Increased sedation is a side effect for all the three major antispastic medications, the baclofen, the benzodiazepines, and the tizanidine. And one thing that I still want to point out is to watch out are GI symptoms, especially the increase in constipation with baclofen is a major side effect. It can be counter-regulated, but I make sure that I point it out to the families to watch for that. Now, when we go to the pharmacological treatment of dystonia, if I mention that we had not many papers looking at the use of oral medication for spasticity, we are actually having less papers and less trials assessing that for dystonia. So this is a nice review in 2018 that looked at not only the pharmacological but also neurosurgical interventions of dystonia. I want to point out to the first two columns where this paper was addressing in this meta-analysis, medications, including baclofen, benzodiazepines, clonidine, and gabapentin, they noticed that for none of those 4 medications, there were actually papers that fitted their criteria. They included only papers that had at least 5 patients, so they did not include case reports that are definitely available, and actually rated all these papers into strength of methodology. And as you can see, the levodopa had actually only in regard of motor function is actually a level C and showed possibly an ineffectiveness to reduce actually the dystonia itself, reduce the pain. It had no evidence. The other medication that is typically considered when it comes to dystonia as oral medication is trihexyphenidyl, or known also by the name of Artane. Also had very weak evidence that is possibly ineffective. Sorry, so that is actually very disappointing, and I have to say that is also my personal impression. In my younger years, I was quite eager to try out, so again, not replacing any controlled trials, but I find that the trihexyphenidyl has quite a lot of side effects when we push it to higher dose, and I've rarely seen wow effects. I will get back to the surgical interventions when I touch on those. There is a care pathway that still is mentioning all those medications, but they're really highlighting that there is very little evidence, or none to nothing evidence that it actually works, but in the sense of absence of something better, they are still having it on the care pathways as an option. Now we'll go away from our oral medications and talk about botulinum toxin injections. This is currently the most frequently used intervention for children with CP. Depending where you practice, you might come across different types of botulinum toxin. In Canada, we have at the moment Botox, and this product is just entering the market, whereas other countries in the world have all formulations. Botulinum toxin A is working by blocking the release of the presynaptic acetylcholine, and in that way reduces the muscle contraction. Different than the oral medication, botulinum toxin will target very specific muscles that we as the professionals have to identify. It is important to recognize that while botulinum toxin treatment is regarded as a focal treatment, you can definitely apply it also in patients that have widespread hypertonia, while you're still targeting specific muscles. It does help in spasticity and dystonia, so in both types of hypertonia. And the aim is to improve function, improve range of motion, but I also wanted to list the possibility of sometimes cosmetic consideration for tone. A lot of my patients, especially in adolescents, are really bothered by the posturing, and it really comes down then to a cosmetic consideration to relax the arm with the clarity that this is not necessarily a functional gain. When will Botox help the most is when the muscle still has a dynamic range, not being contracted. The tool that helps us mostly to identify it is the modified Tardieu scale. We measure an R1, which is the first resistance, or what we often in our neuro exam would be relating to as the first spastic catch. And the R2 is the end resistance. And this difference, the delta between R1 and R2, will tell us how well this muscle might respond to Botox. The Botox is able to push the R1 closer to the R2. We're not able, with the help of Botox, to really push the R2, the end range, further. That requires different means, such as serial casting and possible surgery. And for different muscle and joint groups, this delta is different. So when we look at the ankle, it is from the get-go a joint that has less range, versus a joint like the shoulder has much bigger range. And so it is important to know how children typically behave. We don't have good reference. So if I teach a learner, it is hard to give them an exact range. But for example, for the ankle muscles, when we have even a 10-degree range, that sometimes can be very meaningful, whereas in the hamstring muscles, having only a 10-degree range difference is putting them very close to being contracted, and is often then not very effective to respond to Botox treatment. It is also important to recognize that Botox will help better when high tone is the limitation rather than the weakness or the lack of muscle control. Or differently said, when you have a strong child with good muscle control, their response to botulinum toxin treatment will be better. When we look again at the evidence of the literature, there is plenty of papers, especially in the initial phase when Botox was initially used in children, which was around 1993, so now over 25 years, that showed that botulinum toxin is able to reduce the muscle tone. It also showed short-term changes in improved balance, ability to walk, increased endurance. And a few years later, there were a lot of good work done also on upper limb. When looking actually at the long-term evidence, does Botox actually make a difference, comparing it to patients that have not received Botox? The landscape is actually very meager. There are no good long-term cohort randomized trials. And I have to say, these days, it is extremely difficult to even organize a controlled trial, because Botox has come into such a normal, it's so accessible that, and it's regarded as mainstream, that it's very difficult to set up a research protocol where people will be compared and not receive this intervention. But it is important to really recognize that we don't have good evidence that it really, on the long term, makes a difference. I often have this discussion on a more observational level with therapists and colleagues that have been around for many years, and there's often a feeling that our patients seem to do better these days compared to patients, I know, 20 or 30 years ago, and people related to the use of Botox. And I often wonder if it's not only the intervention, but also the rest of supports that we're doing differently. And a big one that I think has potentially contributed to good outcome is also the more conservative approach with irreversible interventions such as orthopedic surgery, which definitely have its place, but are now deferred, because the feeling is that we have Botox and we can defer orthopedic surgery, and everybody is on board that that deferral might have positive impact. So when we pick botulinum toxin, it is important, like for any intervention, to really set clear goals. We are not just for the sake of reducing the tone injecting. We really want to understand what is it that we're going to accomplish. And goal setting will look differently according to the different functional levels. So in the ambulatory clients that are in GMFCS level 1 to 3, we do want to link our intervention to a functional improvement and ideally increase participation. When we're looking at patients in the non-ambulatory group GMFCS level 4 and 5, then we will be also trying to identify functional goals, but there is definitely a place of consideration for care and general well-being. And the topic of pain is increasing in our awareness, and it's still not clear how much the Botox directly affects pain, or is it the relaxation of muscles that indirectly, of course, reduces then the pain, while it has to be clearly said that not every patient experiencing hypertonia is automatically in pain. It's often the secondary changes to the musculoskeletal that does cause the pain. Is there a role for use of botulinum toxin to maintain range of motion rather than improve? And people had high hopes when 25 years ago we were starting with Botox. At this point, we actually do not have evidence to really say that this is helping the progression of a natural history. In a moment, I'll actually point out that maybe even the contrary, maybe it's actually worsening. Another discussion that was in the forum of specialists is would reducing tone by the use of botulinum toxin help reduce the risk of progressive hip dislocation. And for a while, people strongly believed so, that there was a mechanism that the hypertonia, the scissoring, would actually contribute to the dislocation that is progressive and is very common in our population, especially with GMFCS level 4 and 5. But well-done studies have actually shown that this is not supportive. So despite repeated botulinum toxin injections, this seems to be a natural history to the patients. And no, we're not using Botox to prevent hip dislocation. That does not mean that we won't inject hip adductors, leg adductors, to reduce the scissoring for, again, comfort and for functional purposes. But we need to be very clear in our goals that this is not a protective measure for hip dislocation. So for the longest, we were quite sure that Botox is very innocent and that it works in a matter of a few days, and it's in the body for up to 3 months, and then it's out and the nerves are resprouting. But in the last few years, we are getting a rising concern about Botox potentially actually leaving a mark on our injected muscles, and that it seems to induce atrophy. And what is the long-term outcome of that? 2 of my colleagues from my hometown Munich have actually injected themselves in a healthy gastrocnemius muscles and followed their own muscles with MRI and actually with muscle biopsy, and saw that it took a year for their muscle to change back to normal. In a nice meta-analysis, Matavon in 2015 published a meta-analysis of 21 studies. The majority are rat models, and we need to be careful in converting that to our pediatric population. Only 5 studies included children with CP, and they did not have a control population, and they had various degree of follow-up with imaging predominantly, that also showed very suspicious findings of prolonged atrophy of the muscles. But none of them had biopsies. So this is a rising concern, and at the last American Academy meeting, there was a widespread discussion around the safety of long-term use and how we should apply it. There's definitely a tendency now to be sure that we give the muscle enough time to regenerate. And the higher functioning the person is, the more we want them to really have breaks in between. So ideally at the moment, even up to a year, but I would say at a minimum to wait for 6 months to allow the muscle to strengthen. I did not find any of the studies that actually addressed the potential difference between spasticity and dystonia. From my own observation, I would say even just looking at the muscle mass of children with spasticity, I agree that they often show, even at base, already more atrophic muscle, versus children that have a stronger component of dystonia have often an increased muscle mass. So I would just be very careful to say that there might be difference in how these muscles react also to treatment. So more to know. Another intervention that actually has been long-standing and used prior to the use of botulinum toxin is the alcohol nerve block. And then with the rise of Botox was pretty much forgotten and has in the last years become a little bit more popular again. We at McMaster are using it as a bit of an complement treatment. So we will still provide as a first line botulinum toxin injections. But when we see that the botulinum helps and we're running out of units because there's a mathematical equation of units per kilogram, then we like to combine it with the nerve block. Lessons learned from the times when ethanol or phenol nerve block was used is that the main reason why people stop doing it is that it can cause paresthesias. And this is more so when we use it on nerves that carry sensory nerve fibers. And a lot of the nerves are mixed sensory and motor. So in McMaster, what we have now done for actually many years, at least 15 years, that we are using the nerve block solely to the obturator nerve, which is a pure motor nerve, to help address adductor spasticity. And this is a muscle group that we often need a lot of amount. So freeing up this amount for other muscles makes a huge difference. And we actually have very good observational results. We have not collected the data into a study, so I again want to be very honest about that, but on observations our patients are very pleased with this intervention. And the nice thing about the nerve block is that it does last longer, so 6 to 8 months. And I do wonder if now with the concerns about Botox that will be again on a bit of the popular rise. Now let's move on to the more surgical intervention. So intrathecal baclofen pump is a neurosurgical intervention where a catheter gets implanted into the spine and a device into under the skin in the abdomen to deliver small amounts directly to the spine of baclofen. It's the same baclofen that we have discussed as an oral medication, but the advantage is that you can get better results on tone while you're avoiding the same side effects of severe sedation. It is indicated for both spasticity management as well as dystonia management. It is typically recommended for children with severe level of CP, meaning the GM-FCS level 4 and 5. There are some institutes who will offer it also for higher functioning children in levels 3 predominantly. I wrote here 1 to 3, but that is really, really rare that it would be beyond a level 3. And the main reason for this approach is really, I'll just jump here, to the high rate of side effects of the intrathecal baclofen pump even in the hands of very good surgeons, we do know that the device has a lot of problems and can be quite acute. So another limitation of this intervention is also the accessibility. So even here in Ontario, a family that might live 2 hours from the center that requires to be accessed for emergencies might be too long, because those children can go into severe withdrawal if the pump actually is malfunctioning. What is the evidence saying? So ITP is showing in many different studies a good ability to reduce spasticity. And again, a common thread throughout my presentation, and I want to again and again emphasize it, while we are able with the ITP to reduce the tone, the literature has not been able to identify big jumps in functional gains. And I'm saying it with a bit of hesitancy because, again, we should not downplay also the small gains. And so in this paper from Krach et al. In Minnesota, again, it was interview and feedback of the subjects that were very happy with the improved positioning, transfers, ability to be dressed, and hygiene. So these are all functional gains. But again, when it comes down to goal setting, it is important to clarify that we are not, unfortunately, able to move someone from a level 5, I'm talking GMFCS level 5, to an ambulatory state. So it is definitely qualitative, and we have subtle changes in also the function, but not to a point where we see big changes from one GMFS class to another. The next intervention that, again, a lot of our interventions seem to come and go. So also selective dorsal rhizotomy has been around before and has then become less popular. And I do wonder again if the timing had to do also with Botox taking over, and in the last 5 years has had a re-emerging. So selective dorsal rhizotomy is a neurosurgical irreversible intervention where the surgeon under EMG guidance is cutting selectively the dorsal roots, the sensory roots. So it's not affecting actually the motor pathways, but the sensory pathway. And by reducing this reflex arch, we're creating the reduction of the tone. And it is actually a great model also for learners to see how much taking away the tone, because they come out of surgery and really without the tone, is still not making them stand up and walk. So it's a good example to show how much tone is not equaling the inability to walk. Which is our target population for this type of intervention are the patients with predominantly tone in the leg, the spastic diplegia, and ideally GMFCS level 2. That's really the core population. There are the patients that we have discussions in the level 1s and level 3s that have sometimes also indications. Ideally, in a young age, between age 4 to 8. You want to pick the patients that have good range of motion, no contractions yet, and underlying good muscle strength. Because when you take away the tone, you'll start seeing the true underlying strength. And again, having to emphasize dorsal rhizotomy does not per se weaken the muscle. But if you have weak muscles and the tone was the one that actually held you up, then it will unmask the weakness. And once it's unmasked because you had the surgery, you cannot turn it back. So it's really important to be very thorough in the selection of the right patients. Another point that is really important to understand in the selection is the personality of the child and the family. Selective dorsal rhizotomy requires very intensive, prolonged therapy, and this is not doable for all the children, and might be a reason to defer. So that's part of the reason why we're not doing dorsal very early, a part of the fact that you might not have the full spectrum of the tone yet. There are risks. It is an irreversible treatment. The main worry is the transient urinary incontinence, but in most times it is really transient. But again, leaving a functional person with a permanent incontinence is a problem. Also, the dysesthesia, they're happening very often post-surgically, but then most of the time are transient. There have been concerns about progressive hip subluxation. At this point, we actually do not have good evidence that this is linked. Pain and scoliosis are other things to consider. There have been several papers that overall showed some effectiveness, but then there were also papers in the 90s that were not as convinced that SDR really has a place, and that led to the shutdown of many programs. So Ontario had until 20 years ago a program that was actually closed. And as I said, in the last 5 years, SDR has been of more interest, and it was heavily driven actually by parents. And so in many countries, there were committees put together to re-evaluate. And we have to say that because, as the word says, it's a selective, so only a certain amount of dorsal roots are cut. There is a high inter-surgical difference. So it's hard also to compare centers. So this paper that was published quite recently was actually commissioned by the NHS in England. As they have a very centralized medical system, they often can pull together nicely data. They had 5 big centers come together prospectively looking at children undergoing SDR under a research protocol, ages 3 to 9, which is sort of our classical age, and they had a total of 137 children, and could show that they actually showed significant improvement in the gross motor functional measure. So that's a functional assessment. They also could show that in many of the subdomains of the CP quality of life, the patient and the families indicated improvements. And really based on this study, England went back to having their own SDR program, and during the same time, for example, also Ontario did a similar review of the literature. We didn't replicate the research, but we also restarted 2 years ago our in-province program, and have definitely had several of our patients go through that with nice results, I have to say. Orthopedic surgery is a big basket and really important. In our institution, all the children are co-shared with the surgeon, so I'm less involved in the decision making, and maybe that's why I didn't include it as much. In our institution, really, I have to make the decision who goes to the neurosurgeon for all the other interventions. So I find it's really important to recognize when I have to consider it. I'm not, of course, operating. When it comes to orthopedic surgery, I will just say that you can address the tone also by tendon lengthening. And we do have good data to say that you don't want to do tendon lengthening too early, because the risk is that the tone will come back when you do it very early, let's say at an age of 4. And with each surgery and each tendon lengthening, you will create also a change in the physics of the muscle that weakens the muscle. So it is important to be very conscientious. The right children with the right surgery do very well, and there is absolutely a place for it. But the tendency is to try and defer it as possible and rather go to bony surgery, derotation osteotomies, as the bone heals very well, and not touching the muscle in its core is having long-term better outcomes. But I will stop at this point with the orthopedic surgery. So at this point, having gone through all the different modalities that we can consider, it is a very clear yes, we can reduce tone. But the bigger question really is, do we need to reduce tone? Do we need to reduce tone for every child and at every stage? And if yes, which intervention would we use? So I want to go back to my earlier slide of the hypertonia and the positive features and the negative features, and really remind ourselves that it needs to be integrated. It's wrong to just look at the hypertonia and go through all the modalities. We need to understand how the hypertonia interacts with the negative features to inform us in our decision making about which direction to go. And it often is an integrated. It's not one or the other, it's rather one and the other. What helps to come to the right decision? So start with a good assessment of all physical features. Again, we are very good in doing that part. We're not as consistent when it comes to assessing the strength. And sometimes it's really difficult, especially when the child is young. So we can't really involve them in strength testing, but we need to apply our observations. We need to see how are they squatting, how are they able to do stairs, get information about the endurance, the muscle control. Observing them is really important. How can they generate the movements? Selective control is a big ability, but again, when they're very young, it's hard to actually get to the bottom of it, and so is the sensation. Next point is really have a good discussion. A lot of patients come to us neurologists with the hope that we have something to offer to fix their child. Unfortunately, without sounding too negative, we do not have currently an intervention that can cure cerebral palsy or can cure spasticity in its holistic way. We can reduce the tone, but the core features, especially the difficulty in controlling the movement, will continue. So having a realistic discussion around what's doable is important. I want to bring up also that in this discussion, it's really important to consider the ICF framework, and I'll show a slide in a moment. And as McMaster representative, I cannot but mention also the F-word paper, which I'll get to in a moment. And really, tone management should never be a standalone. So I did not express enough throughout my talk that all these interventions need to be supported by therapy, especially physiotherapy, occupational therapy, and bracing. The goals that I mentioned might look different for levels 1 and 3 that are the ambulatory, and the level 4 and 5. We talked about it already. And so just to remind us all about the ICF framework, where tone would fit under the body structure. That is what we affect. But we really want to see that it is going hand in hand with some change in activity and participation. If it's purely to just reduce tone, then I'm not sure we really need to go there. But things like comfort are important in the end, will also then affect activity. Environmental factors and personal factors, as I mentioned earlier, are very important too. It really is important to understand what is meaningful for the family. What will they be able to participate? How can we engage? So a brief word for those who might not have heard about this very challenging paper of the F words. Of course, we are meaning not this F word, but another few F words that include fitness, function, friendships, family factors, and fun. This is a general philosophical approach to really understand that treatment in chronic conditions, and it's not specific to CP actually, really requires the integration of those efforts, because you cannot sustain and be meaningful if you don't relate to them. I want to use the last few minutes to just do this quick review, because again, while I don't want it to be perceived as a recipe, it helps to maybe organize the information I have provided. So when I look at a young child referred for question hypertonia management, that is JMFCS 1 to 3, oral medication is often on my list to discuss, but I would rarely use it because the young children seem to have more side effects and less effectiveness on the function. Botulinum toxin is definitely something I will continue to consider and has shown effectiveness in reducing tone. And we do see that the young child receiving Botox does often a very quick jump up it's more like a step up in the trajectory that is anyway going upwards. So we often will explain to the parents that the child will get to the next level probably regardless, but the Botox will often make it quicker. And right now it's really important to highlight still the unknown of the long-term effect and be rather conservative with the re-injections and the time intervals. SDR is, as I said, on the rise and should be considered for the children GMFCS level 1 to 3, and typically will be referred to a tertiary level center that can really do the appropriate assessment. Orthopedic surgery should be pushed away, but has a role, and we see especially the hemiplegic children that have very early contractions in the leg, often still requiring tendon lengthening. And intrathecal baclofen is not an option at this point for the high functioning children. The young child, and when I say young child, I'm cutting off at school age, sort of 6, GMFCS 4 to 5, again, I would say has somewhat more indications for oral medications, but still the limitations that they might have still side effects. So be cautious in your dosing. It's easier to go slowly up than to lose the parents' will to continue. When they experience side effects, they had enough of the medications. Botulinum toxin is definitely, in my opinion, has a place. There's actually very little literature specific for GMFCS level 4s and 5s, but for positioning and caregiving. But I often find these children are a little bit older, so not the very young, they're not the 2 and 3-year-olds like the level 1 to 3, but the older they get, we start seeing the tone ramp up. Often in the initial phase, the parents will say that they can still handle, they can still diaper, they can still dress, but then often over time, this becomes more challenging. SDR is typically not mainstream, but there are centers who are starting to explore. So maybe future will tell us that there are modifications to the SDR with another indication, but again, not with the purpose of turning a GMFCS level 4 and 5 into an ambulatory kit. That would be a wrong goal. Orthopedic surgery is definitely something that is required at times, especially when it comes to hip dislocation, which is a common feature, not necessarily at a young age, but over time. And intrathecal baclofen would be of interest, but typically the young children are just too small to house the device. So depending on the size of the children, but most of the time I find our local neurosurgeons will not implant before they're actually into even adolescent. Now, the school age children, level 1 and 3, oral medication becomes maybe more of a need, especially when they're experiencing more painful spasms. Botox will be less effective over time, but still might play some role. I find the upper limb seem to be still responding. That's an observation. I did not find any papers to really support my observation, but I definitely can say that on, again, observation, I feel what is also being described with the papers with the atrophy, that often the first 1 to 3 rounds of Botox seem to still be quite effective, and then all of a sudden they're not as effective. They're still seeing a difference, but it's just shorter and not as dramatic. Sorry, I'm starting to get blocked in my views because of those hands up. The SDR is typically at the moment capped for age 8. We had a few patients that were slightly older, so I don't know how much this will over time be a rule, but what we see is often that the older the child gets, the more they become contracted, and so SDR is just not the right intervention when you're starting to see muscle contractions. That's why we typically cap it. But if the patient has no contractions, high tone, then I don't think the limit of age 8 should be written in stone. Orthopedic surgery, as I said, needs to be considered, and ITP would be very rarely in the school age high functioning child. When it comes to the school age GMFCS 4 and 5, then again with age, as I mentioned, more need for potentially medication. I have to say, actually, now in COVID, where we could not bring back our patients that used to get regular Botox, I have shifted several in a more aggressive way to medications. And I definitely saw in some patients a benefit, which I think, again, we all go through phases of our own experiences. So I was more hesitant before in really pushing the meds up because of side effects, but when you don't have an alternative, you do it. And so it's interesting to see a bit of the shift again. We typically don't do SDR, as I mentioned before, in the higher levels, and definitely in the school age, the hip dislocation is a big one that is starting to be seen, and we have high percentages in level 4 and 5, unfortunately. The two, sorry, I'm jumping here. The two last group that I wanted to put apart is, again, why they're fitting also into my general overview, is that hemiplegic patients, I find, have a very high level of stiffness, often very focal. And so I rarely use oral medication for them. I don't see it really helping. The Botox in patients with hemiplegia is definitely warranted, often initially for the lower limb. But I also find that many of the hemiplegic patients, especially when they're sort of in the second decade, get sort of a superimposed dystonia of the arm. And that very specifically is responding actually quite nicely. But again, I could not find literature to really talk about this more specifically. We are not seeing SDR done in mainstream, but I know that there are centers across the world who do offer it to families, and I have not seen any publication on that. Surgery is definitely relevant in hemiplegia for early contractions of pes equina varus, and no, we don't typically do intrathecal baclofen. And the last group that I wanted to highlight are the children with more specific dyskinetic CP, where oral medication, as I already pointed out, are not promising at the moment. Botulinum toxin for the very focal dystonia. So again, the children that are GMFCS level 4 and 5 with significant dyskinetic CP, I don't see as much of a value at all for Botox, but those who have the more focal participants, then yes. SDR is actually contraindication. SDR does not treat dystonia, so we do not offer it, and it actually can make it worse. With surgery, again, that's where it's really important to separate this spasticity and dystonia, because surgery can go really wrong if we misunderstand the tone. And definitely intrathecal baclofen is an option. And I didn't put it in because it's actually very new on the horizon, but deep brain stimulation is an area that is now developing and has very good results in dystonia in the context of genetics. The numbers and the results on children with dyskinetic CP are not as good, but they still seem to have some effectiveness. So that's on a side note. And that brings me to my end, and here wanted to just share a few pictures of our city, Hamilton, and this is McMaster Children's Hospital, and I'll be happy to take questions.
Shaheen, are you there? Dr. Shaheen?
No. Hello, I cannot hear.
You can't hear?
No.
Dr. Shaheen, can you hear me?
Yeah. Now I can hear you.
Yeah.
Thank you. This
Yeah.
is a very nice and comprehensive presentation, and it's a very common problem also in our country, the management of spasticity. And you rightly started with the tone assessment, and that one, the positive and negative signs of this is very useful. I think this is a very important one. And also use the assessment of hypertonia and when to consider oral therapy, when to go to the next one, and the lots of uh, papers, and you have shown what are the indication, what are the side effects. I think it's very nicely presented. And the last one, whenever we we also like the one that whenever we start the treatment, so better to remember the ICFCY thing, that is the function and the activity and the participation. This is very important. And next that you described about the if condition, that is very helpful, and it's a very nice thing to remember. It's very nice. And other things you also shows the last one, the last slide, that was also very important. But one thing, can I ask just one thing?
Yeah,
So,
sure.
yeah. What about, so you also told about the deep brain stimulation. What about something like stem cell transfer that sometimes is used? Even some of our patients, especially, they have gone to India and asked whether this stem cell, one of this, maybe privately, maybe they are doing this stem cell transplantation for this stem cell therapy. And another thing, what about something on transcranial magnetic stimulation? And lastly, cannabidiols. What's your experience in using cannabidiols in?
Yeah, and I see that there were a lot of really, really good questions, and I'm happy to go through all of them and give my comments. So again, I think a lot of the interventions are, again, more interventions for functions. It's hard to, I wouldn't categorize them as an intervention necessarily for tone. And so again, stem cells, I was eagerly watching, there is an ongoing trial in Duke that has two research protocols. One is actually babies born with HIE that get their stem cells harvested and right away reinfused. And then they have another protocol where children that had been harvested stem cells at birth, but without the knowledge that they'll develop CP, and now years later they get their own stem cells reinfused. The papers are just starting to come out. I think it's too early to say much, but from what I've seen, I would be very careful. I would be very cautious. It definitely has not shown to cure those children. And I think part of the challenge of deciding how much a treatment is helping, and one of the questions was also about the natural history. I think that's the big issue. We're dealing with children. They're born, and while CP is described as a static encephalopathy, it is a process that has stopped. The changes on the body are changing, right? Their musculoskeletal presentation, their tone, the contractures, they are changing over time. And so it is sometimes hard to separate what's the natural history. We know a lot of the children, let's take a child in level 2, you know, they don't reach their typical milestones on time, but they have their own trajectory. And when you treat them, it often makes the parents feel, yes, that's because of the treatment, but we know the child would have reached those goals anyway. And how much did our intervention make the quality better? How much did our intervention truly speed it up or get them to a different point, right? And I think that makes our studies so difficult with the conclusion. So I would say for stem cells, I tell my patients to be very careful, and I actually don't recommend it. The transmagnetic stimulation definitely has shown good results in patients with hemiplegia. Again, as far as I remember the results, it was again more showing the function rather than, and again, it works on the pathway. So it is a very interesting concept. Again, I didn't touch at all on even just therapy. We have very nice studies in interventions like constraint-induced movement therapy, where we know that we're changing the brain plasticity. So I definitely see a role. Again, I focused really on these medical interventions today, but there is a role to look at other interventions. You also asked me about cannabis. Again, I just briefly scanned, and I was thinking, should I pack it into this talk as well? And there is right now still sparse publications. I mean, at the meetings, we're starting to hear first reports. There is evidence in tone management for adults. I think where it becomes sometimes hard to separate on the link is also, so one of the questions I saw was also about the use of gabapentin on dystonia. And again, I will definitely use it, but I'm still not sure of what's the connection, right? We know when people have emotions and pain, their dystonia will go up. So if the gabapentin helps, I'm not sure I would blame it on it being antidystonic, but I can really see that it reduces pain that we know is more frequent in children with GMFCS level 4 and 5, and that might also reduce the dystonia. So again, what's the chicken and the egg? How is it an association or is it a causal effect? I'm not yet sure.
Thank you.
Okay, Dr.
Thank you.
Dr. Akhtar, to have your permission to ask a few questions.
Yes.
I'm sorry, I'm taking too much time.
No, not at all. It's very interesting. Those were really important questions. So we have questions from our participants, and I will just put them to you one by one. So
Yep.
someone is asked, till what age can Botox be given with good benefit?
So I don't have a categorical answer to say you cannot give beyond a certain age. We also know that Botox is used in adults who have stroke, so there isn't an age factor. But I do see a change over time. So when you start seeing less responsiveness, that's what should drive it. But I also can share that I've seen children that did not get Botox at a young age because parents were worried, and I see them when they're teenagers, and I call them Botox naive, and they have very good response. So I actually think it has more to do with the frequency that often levels off than actually an actual age factor.
Okay. And do you feel that it can really change the natural history of CP is another question.
My blunt answer is no. Like,
Okay.
I think it has a role, but that's what I try to get across. And it's not just Botox. I think it's all the interventions we have to offer are unfortunately not able to fix. And again, how much does it change the natural history? Yes, there is wiggle room, I call it, right? So you can improve the quality, and it often is very meaningful. And so I would still consider all those interventions, but when we talk about can it change the natural history, we really envision a huge change, right? Taking someone who is a level 5 into a level 2 or even a 3 is not typical.
Okay. Do you monitor liver function tests when you're using baclofen?
I actually don't.
Okay, so you would just
I monitor the clinical features, and again, yeah, I don't.
So Dr. Deepa Saha wants to know that in some cases of cerebral palsy in early childhood, they found hypertonia, but had no neck control.
Yeah.
What do you think is the pathophysiology behind that?
Ooh.
If you can give a short
like
the distribution of spasticity.
it has to do in how our nervous system is controlled. I think it has to do with the reflexes that we also see when we cup those dorsal efferent, then we don't have spasticity. But I don't have a good now quick out of my sleeve explanation for the anatomy and the physiology, but I agree that's this combination is what we see all the time, and people get a little bit confused when they're not knowing this population, but this goes hand in hand, the hypertonia of the arms and legs with the reduced neck control. Yeah.
Okay. Is baclofen contraindicated in children with seizures?
So I would not contraindicate at all. What we do highlight is there is, again, it's described, I personally have actually not seen it, but that if you are on baclofen, you're abruptly stopping it, that you're at a higher risk of exacerbation of seizures. So it's not so much the induction of seizures, then rather than it is GABAergic, it works on your brain, so don't take it away abruptly. I have lots of children with epilepsy and baclofen, and even those who, because of intercurrent infections, haven't been able to take the dose, I actually have never seen a huge problem. So I would not be worried about it. I still do it, and yeah. But we need to counsel, otherwise parents will be upset if it still happens. I can't say it can't happen, but I think it's too good of a medication, and too many of our patients have seizures associated that we would really holding off something that could be beneficial.
So Dr. Mahesh Kamte wants to know that in India we have mixed cerebral palsy more commonly than spastic CP. So do you think it's a good practice to combine baclofen with trihexyphenidyl? And what do you think is the role of tolperazone in spasticity management? Some years back we were using it a lot, but it seems to have gone out of fashion again.
Okay, so I again, if you look at the pathway of the American Academy, they will also say that the first line is baclofen and trihexyphenidyl. Especially when it comes to mixed, I will always use baclofen as the first line because it is covering spasticity and dystonia. And then, yeah, if I don't get where I want to get, I will consider also trihexy, but they both do significant constipation. So when you combine it, you need to just be very aware of it. And again, how well would it work even when you combine it? I would say it's still limited. So, and the other thing to point out, when we use trihexyphenidyl, I mean, children with dyskinetic CP are not just dystonic. They have dystonia, but they often have also choreatitosis. and that actually can get worse with the trihexy. So again, it's tricky and unfortunately not showing huge results. So one thing that I did not mention is that I have seen a few kids that have dyskinetic CP and have in between dystonic crisis. So they definitely require quite a cocktail and even admission and up to a place where you put them temporarily into coma because they're going to such a strong muscle breakdown. So there is a place to ramp it up, but it becomes a balancing because the side effects when you bombard them with a lot of medication is heavy.
So you'll be happy to know that Dr. Veena Kalra is here with us. She's actually the founder of this Association of Child Neurology way back in 2002. So she wanted to ask you something. Dr. Kalra, are you there? Is she there? Dr. Ramesh, can you just unmute her?
Yeah, she's allowed to talk, ma'am.
No, I can see her mic is off.
Yeah, ma'am has to unmute.
Is it okay?
Yes,
yeah.
Okay.
Good evening.
Hello, good evening, everybody. Good
Hello.
evening. Very nice talk, Ronit.
Thank you.
I have a question about what is being used very recently, the stimulation of the agonists and antagonists by various suits like the Molly suit, which have come into a lot of talk in recent 3-4 years.
Sorry, which medications are you referring to?
No, these are not medications. These are devices. These are devices that they use for tone regulation. Physical devices on the muscles that they use for tone regulation.
Like a TENS, you meaning?
It's called a Molly suit. M-O-L-I. M-O-L-I, Molly suit. So this sort of has points on the agonist and antagonist, and as you walk, it stimulates them alternately, which helps to modulate tone for function. And this is something that's come up very recently in the last 2-3 years. And there's a lot of research and action going on in this field.
So I don't have a lot of experience, so I don't want to comment without really knowing. I do remember one child that I saw in my clinic that also ordered it online, and that was not very successful. It actually almost sort of stimulated the wrong place, and the foot started going to another place. So I think it probably has potential if you are able to correct a gait, but I do not want to comment too much about it because I'm really not very familiar with that.
Thanks.
Thank you.
So there are still some questions if you're ready to take them.
Yeah, I'm happy. So I see that, again, several questions around infancy and medication. So my general take is that I'm hesitant in infancy. I find rarely that the kids manage well. And again, taking away their tone is not making them function better. And that should really be our goal. So I'm not a big fan of medications in infancy.
But do you think reducing tone in infancy would perhaps delay the contractures? In India, the patients come to us really late, often.
Yeah, I don't think we have evidence at all that actually any of our interventions, including the Botox, is, again, that was for a while the thinking that the Botox maybe could delay it, and we were fairly disappointed in not seeing it. And again, we're still waiting for good papers. We were running a 3-year follow-up randomized trial at McMaster with Toronto, where we actually used young children, and it's not yet published, but I can tell you off the press that we didn't find significant differences in a randomized trial. So I think we all need to get out of this loop of thinking that the contractions are driving it. I don't think so.
So someone wants to know, what is the treatment for status dystonicus? Like you said.
Yeah, it's again typically a combination of. I would start with probably benzos, high dose benzos to really relax, sedate. Benzos are highly antispastic. We would probably combine it also with other medications like clonidine, baclofen. So I did not have many patients, but when I had them, it's actually difficult. You often need to just put them into a sedative. It's not even so much this antispastic. You can try to just give them a high dose of diazepam, but if it's not working and they're having CKs in the hundreds and thousands, then you need to really look at it as a required admission and sedate, even put them into a bit of a sleep, like in a status epilepticus, and then see if, when they wake up, if it's working better. But the literature gives you sort of a protocol. I can't say that it's very easy or highly successful. And I've spoken to a lot of international colleagues when I had 2 or 3 of these really tough cases, and I had to understand that they're all struggling. So it's, yeah.
Some people have tried giving muscle relaxants, put them into sedation and give muscle relaxants and like scoline, etc.
Yeah.
That can help sometimes, I think. So, can you share your experience of using tizanidine and tolperazone?
I don't use tizanidine a lot because it has to do with how we are funded. So I have a number of kids that, again, it's my 3rd line. I typically start with baclofen and then with diazepam. Again, by the time I also add the tizanidine, they are sedated. But it's overall, I had a few where I did it as a 1st line, and so I'm not sure it's truly superior. Let's put it like that. I don't think we have good head-to-head studies. There are some studies showing that diazepam and baclofen are fairly equal. And I can say I will always start with baclofen because I'm a little bit more nervous about the dependency that develops with benzos in general. So that's my argument why I would start with baclofen. I don't have a good sense of a priority between tizanidine and baclofen, but yeah, I have patients who have a cocktail and they're good. What I also would say, that sedative effect of all the meds improves over time. So you really want to go slow and reassure them that often what they see initially isn't staying. But in the end, it comes down to what is it that we're trying to accomplish, right? If the child is not in discomfort and we're not seeing functional changes, then I will often not maintain them on these meds because I really don't see the purpose of it.
So Dr. Pratibha Singhi wanted to know, what is your protocol for management of dystonic CP and your experience on the use of robotic devices and virtual reality?
Sorry, I'm looking where it's, can you say it one more time?
10:20. So Dr. Pratibha Singhi, she's a very renowned pediatric neurologist here. She was the head of the Department of Pediatric Neurology in PGI Chandigarh. And so she wants to know what your protocol is for the management of dystonic CP, and what is your experience on the use of robotic devices and virtual reality?
Yeah. So again, dystonic CP, and again, I would call it more dyskinetic because patients are rarely only one thing. So the dyskinetic have often a combination of dystonia and choreoathetosis. If it is more dystonia, then I would still apply the things that I mentioned. So often medications and also even Botox and also the surgical intervention. If it's more choreoathetosis, I would say the meds and the intervention are much more trickier, and I will much more lean on how to accommodate them, right? I find often stabilizing them, having good seating, sometimes strapping the legs helps in functioning of the arm because the body is not flailing. So really going back to the more basic interventions makes often a difference. The other piece is dyskinetic patients often have a much more disparity between actually very preserved cognition and really impacted motor. So again, rather than being too focused on their actual movements, which I do not see that we have good suggestions at this point, I do like to really look at more the environmental supports, meaning early access to power wheelchair, early access to good communication, because a lot of these patients will be nonverbal but very communicative and with very good understanding. So that is for me a much more of an interest than going after all the different devices. And again, it's hard to stay on top of everything because people are ongoingly on search. They constantly want to find the fix. And so there are a lot of devices that are getting offered to change. And when I discuss it with parents, and virtual reality is like the games are a good one, that I think the word is still outstanding how much we can change trajectory. But first of all, going back to my effort paper of my colleagues, if this is fun for the children, if that is a means to connect with other children and being like a child and being interactive, then I would say I would support it. Can I at this point say that this will fix dyskinetic CP? I think the verdict is still out.
Okay, so I think we are done with the questions. Dr. Shaheen?
Yes.
So would you like to share some of your experiences in Bangladesh? I'm sure we, like us, you also see patients coming in really late.
Yeah. That's right. Actually, I work in a. I already told you have introduced me in a center that is neurodevelopmental and autism center in pediatric neurology. So here in the outpatient, 1/3 of the patients are actually CP and they come late. Most of the patients are late. So, and our first we do this after the assessment and goal assessment, what we do, that you have actually Dr. Ronit said everything, most of the things are same to us, the goal assessment. And one thing is including the parents so that they can do this physiotherapy after learning from the therapist their home, because it's very difficult to come regularly. And before that, we use the oral drugs when possible, that you've already mentioned. And other things, actually, botulinum toxin, yes, it is also given, but the intrathecal pump, it's not in case of children, it's not possible here. And
if it is some help, believe me, we have very few that we get through the stages. And even if I think I would want it, it's very restricted. So it's not that we have easy access either.
Okay.
Physiotherapy and oral medication and botulinum toxin. And what I told that he already mentions the using this classification system, function classification system is better, because while doing something, while doing hyper spasticity, if the muscles are already weak, then it becomes very difficult. That swelling problem, that is feeding problem. And lastly, the contextual, the environmental things, that is actually different in different, it depends upon the education of the parents, the patients who are intellectually disabled, they don't have so much, but they don't can't have the so much participation in the society, and they don't have that much hope and dream. So that's the thing that's very difficult to manage, these contextual things. Other things we try with limitation, but in the community, uh, one thing we have observed, that the way the mothers carry the children, like the two sides, it's a very, very good practice. And if we can show them and learn them this physical therapy, how to reduce the spasticity, I think they can pick up very early. And of course, with some drugs
Well,
and
so I didn't talk about early intervention. And again, our focus in early intervention and in general in intervention is actually not with the mindset about specifically targeting tone, but really targeting motion. And we know that that is the biggest change over time. So again, when you get a child to do something again and again, it will improve their motor function, but they have to have incentive. They have to want to do it. If it's forced on them, whether it's through therapy or because the parents say you have to do it, it's going to be very difficult. So again, I didn't touch on it, but we have nice studies that really show that the goal-oriented treatment focus. And if I have a child that comes to me and says my arm is stiff, I will ask her, so what do you want to do better? And she will tell me, I want to brush my hair, I want to shower myself. And then we need to incorporate those activities. And then yes, the tone reduction could be this 5% of making it easier. But I cannot tell you with certainty that she wouldn't reach it even without it if we would identify those goals. And that's a good study. So again and again, I need to emphasize that it's a bit of like a little push when we do the tone in treatment in the context of goal setting. Yeah.
So thank you, Dr. Ronit. That was a really wonderful talk. And you're happy to know that there were 189 people attending your talk. So that's a very good number. And Dr. Shaheen, thank you very, very much for sparing your valuable time and joining us here today. Thank you, everybody. And thanks to all the participants who took such a keen interest in this talk and joined us today. Thank you very much.
I must say,
Thank you
your
very much.
European is great. You're great. Yes, thank you. Thank
Okay.
you.
Bye. Keep well, everybody.